episode 3. So it may be of interest and of value to measure pulmonary blood flow. Because if we measure blood flow through the pulmonary circulation, we have essentially measured cardiac output. So as we said before, all of the cardiac output goes through the pulmonary vasculature. So we can measure pulmonary blood flow. That is cardiac output. And the way that cardiac output is commonly measured is by measuring pulmonary blood flow. The traditional way, and in fact till today, the gold standard for measuring pulmonary blood flow and cardiac output is the Fick equation. The Fick equation says that cardiac output is equal to oxygen consumption divided by the arterial oxygen content minus the mixed venous oxygen content. So, as it comes to arterial oxygen content, easy enough. Draw blood gas, look up the hemoglobin, calculate the content. We all remember how to do that, right? So we can measure the arterial oxygen content easy enough. Getting to the oxygen consumption is more difficult. So that requires the use of a metabolic cart, which costs $30,000 or $40,000. They are really difficult to maintain and to calibrate. And I don't know, Vinny, if you've had any experience with metabolic carts, but they are a pain to keep them working and to get accurate numbers and so forth. But there's a way around that. And that is we can estimate the oxygen, we can measure the oxygen consumption or the oxygen uptake from we can estimate that from the carbon dioxide production. So easy enough, we can get carbon dioxide production using the NICO or the NM3. So that gives us carbon dioxide production. And the relationship between carbon dioxide production and oxygen consumption is the respiratory quotient, which is normally 0.8. And it varies. Physiologically, it varies between 0.7 and 1. So it never varies much from 0.8. It's impossible for it to be much different than 0.8. So if we measure the CO2 production with a NICO, we divide it by 0.8, that gives us a reasonable estimate of oxygen consumption. And if we draw a central venous blood sample and measure the central venous blood gases from a central venous catheter rather than from a PA catheter, that gives us a reasonable estimate of the central venous oxygen content. Technically speaking, the central venous oxygen content should come from a sample of blood drawn from the distal tip of the pulmonary artery catheter. So the ideal, perfect way to get mixed venous oxygen content is to draw a sample of blood from pulmonary artery catheter. But most of our patients don't have pulmonary artery catheters anymore. But many of our patients have a central venous catheter, so we can draw a blood sample from the right atrium rather than from the pulmonary artery and use that to estimate the central venous oxygen content. Now it's not perfect because depending upon where the central venous catheter is sitting, we may get blood primarily from the superior vena cava or the inferior vena cava, and there isn't very much mixing, but it is, or I think clinically, often it is good enough. So then we have all of the tools that we need to measure cardiac output, pulmonary blood flow from the Fick equation by some workarounds and making some assumptions, which is less than perfect, but probably good enough for everyday clinical use. And this, again, shows the position of the pulmonary artery catheter. So ideally, mixed venous oxygen content should be drawn from the distal tip of a PA catheter from the pulmonary artery. But a workaround is to draw a blood sample from the from the central circulation, from the right atrium essentially, and we can get that from a central venous catheter. So as illustrated on this slide, or as is indicated on this slide, there are clinical things that increase pulmonary vascular resistance. There are some things that decrease pulmonary vascular resistance, and there are some things that might either increase or decrease pulmonary vascular resistance. So pulmonary vascular resistance might be increased by a loss of vascular bed, such as with emphysema, for example. So with emphysema, there is alveolar destruction, and that destroys not only alveoli, but the accompanying pulmonary capillaries. Pneumonectomy will result in a loss of vascular bed because of a loss of lung parenchyma. Positive pressure ventilation can increase pulmonary vascular resistance, and we'll see how in a minute. Hypoxia increases pulmonary vascular resistance, or perhaps more specifically, hypoxemia. So that's hypoxic pulmonary vasoconstriction. More about that in a few minutes. With vascular obstruction, there's an increase in pulmonary vascular resistance. That's pulmonary embolism, as we'll talk about towards the end of the presentation. And then there are patients who we see who have idiopathic pulmonary arterial hypertension, and that's something you don't want to get because that has a very poor 5-year survival. The outcomes are not good. Things that can decrease pulmonary vascular resistance are sepsis. So sepsis causes vasodilation, systemic and pulmonary vasodilation. An increase in vascular pressure, perhaps paradoxically, decreases pulmonary vascular resistance. And we'll see how in a minute. And then there are drugs, pulmonary vasodilators, that can decrease pulmonary vascular resistance. They include non-selective pulmonary vasodilators, like nitrite and calcium channel blockers, as well as selective pulmonary vasodilators, like inhaled nitric oxide and inhaled prostacyclin. And then lung volume might either increase or decrease the pulmonary vascular resistance, depending upon the level of lung volume. This illustrates the effect of vascular pressure on pulmonary vascular resistance. So here we're looking at pulmonary arterial pressure, here we're looking at pulmonary venous pressure, here we're looking at pulmonary vascular resistance. And as you can see, as the arterial or venous pressure increases in the pulmonary circulation, an increase in pressure in the pulmonary circulation, the resistance actually decreases. So if we volume load our patient, for example, and we increase the pressure in the pulmonary circulation, that will cause pulmonary vascular resistance to drop. So why is that? Well, that's because of two things. Whoop. Let me show you again. Here we go. Thanks, Liz, but it's hooked up to this computer. I just pressed the wrong button on my clicker. So the reason why pulmonary vascular resistance decreases as pressure increases is because of two things. First of all, normally, some pulmonary capillaries are collapsed. So that's illustrated by this one and this one. So that's normal. If we increase the pressure inside of the pulmonary vessels, that will cause those collapsed vessels to be recruited. So now there's blood flow through this vessel and this vessel where there was not previously. The result of that is to increase the cross-sectional area for blood flow. So if there's a larger cross-sectional area for blood flow, there's less resistance. And then the other thing that happens is that pulmonary blood vessels, because they do not have a lot of smooth muscle, are very distensible. So if we increase the pressure inside of the pulmonary vasculature, that causes dilation of the pulmonary vasculature, and that dilation of the pulmonary vasculature again increases the cross-sectional area for blood flow. So with an increase in pressure in the pulmonary vasculature, there is a decrease in resistance to flow, and that is the result of recruitment of otherwise collapsed pulmonary capillaries and distension of already open pulmonary capillaries. And again, that's the result of the pulmonary circulation not having a lot of smooth muscle, so it's very distensive. So interestingly then, if your patient is volume loaded and the pressure in the pulmonary vasculature increases, the resistance to blood flow, maybe kind of paradoxically at first blush, goes down. The other way that we can affect, and we actually very directly here, all of us in this room can affect pulmonary vascular resistance, is with the administration of vasodilators. And those can be either systemic vasodilators, like nipride or calcium channel blockers, or they can be inhaled vasodilators, like inhaled nitric oxide, inhaled prostacyclin. So what happens if we administer a systemic vasodilator? What happens in the pulmonary vasculature if we give the patient something like nipride? Well, a drug like nipride will dilate the vessels going by functioning alveoli, but they will also dilate the vessels going by shunted parts of the lungs. So for you or me, it's not going to be a big deal, but if your patient has ARDS and has a lot of vessels that are going from the right side of the heart to the left side of the heart without participating in gas exchange, because alveoli are consolidated and they are collapsed and so forth, edematous. So the result of increasing blood flow not only past ventilated alveoli but non-ventilated alveoli is that the shunt gets worse and the PO2 goes down. Despite that, both the pulmonary vascular resistance and the systemic vascular resistance go down. So maybe a take-home point from this slide is systemic vasodilators increase the shunt in patients with lung disease, such as patients with ARDS, and that makes their blood gases worse. And it's been known for 40 years that if you administer nipride to a patient with ARDS, their oxygen saturation, their PO2 gets worse. So not a good idea to administer a drug like nipride to a patient with pulmonary disease. Now what if we administer the vasodilator by inhalation? So inhaled nitric oxide, inhaled prostacyclin. Now what happens is there is selective vasodilation to the area of the lung that sees the inhaled vasodilator, but not to other parts of the lungs that are diseased. So now the pulmonary vascular resistance goes down as it does with the systemic vasodilator, but in this case the shunt goes down and the arterial oxygenation goes up because there's better matching between ventilation and blood flow. So the reason why patients with ARDS have an improvement in their PO2 if we administer an inhaled vasodilator like nitric oxide or aerosolized prostacyclin is that it steals blood flow from the sick part of the lung and redirects that blood flow to the ventilated part of the lungs, so it makes the shunt and the VQ better. Moreover, the effect may be isolated to the lungs so that there is a reduction in pulmonary vascular resistance but no effect on systemic vascular resistance. So that makes it a selective inhaled pulmonary vasodilator because it selectively dilates the healthy part of the lungs, and the effect is primarily in the lungs, very little systemic vasodilation. So why is that the case with inhaled nitric oxide. So why does inhaled nitric oxide have a pulmonary vasodilatory effect, but not a systemic vasodilatory effect? So this is the audience participation part of it.
What was the question again?
All right, now that I woke up.
No,
Sorry, I didn't mean to. So the question is, why, if we administer inhaled nitric oxide, does the effect remain regional in the lung, decreasing the pulmonary vascular resistance, but not the systemic vascular resistance? So why does the PA pressure go down, but the systemic blood pressure does not go down? So what is it physiologically that causes that effect?
So because it's inhaled, so it goes to the lungs. The lungs has a lot of capillaries around, and then it doesn't have much less to go to the circulation. So most of the gas gets concentrated in the lungs.
Well, you would think, except that nitric oxide diffuses across the alveolar capillary membrane very well. In fact, so much so that years and years ago, there was interest in using inhaled nitric oxide to measure diffusing capacity, like we use CO. So it gets into the lungs.
Does it have to do with absorption? Like, is it just absorbed so quickly into that one area that it doesn't get the chance to circulate to the rest of the body first?
Not really. Okay, the reason is because hemoglobin has a very high affinity for nitric oxide. So the nitric oxide gets into the lung, it gets into the pulmonary capillary, but then it is immediately scarfed up by hemoglobin, because hemoglobin has an affinity for nitric oxide, which is even greater than the affinity that it has for CO. So the hemoglobin just gets bound up by the nitric oxide just gets bound up by hemoglobin, so then there's not free nitric oxide to produce downstream systemic vasodilation. And then what happens to that hemoglobin? So what happens when the nitric oxide binds onto the hemoglobin? Pardon? So it produces methemoglobin. So it produces methemoglobin, which is why we measure methemoglobin levels, particularly with high doses of inhaled nitric oxide. So the price that we pay for the selective pulmonary vasodilation with nitric oxide is the potential for methemoglobinemia. All of us have in our bodies, and our patients have in their bodies, enzymes to break down the methemoglobin pretty quickly. So usually with lower doses of NO, which 20 parts per million or less, you don't see a lot of methemoglobin. But you probably remember we were given 80 parts per million to our patients, and we would see methemoglobins of 8-10% sometimes. So what about if we use an inhaled prostacyclin? What gets rid of the inhaled prostacyclin in order to avoid effects downstream on systemic vascular resistance? It's kind of a trick question. So the answer is that the same thing that happens with inhaled nitric oxide does not happen with prostacyclin. And in fact, the prostacyclin does get into the bloodstream, but usually the dose is low enough that it does not cause systemic vascular resistance. But with larger doses of inhaled prostacyclins, 50, 60, 70, 80 doses of inhaled prostacyclin, don't remember the units off the top, nanograms per kilo per minute. So at those kinds of doses, 50, 60, 70, there can be spillover into the circulation and the blood pressure will drop. And Dan can help me with this, but that first using inhaled prostacyclins in cardiac surgical patients, starting them out at a dose of 50, that was happening not unconcomitantly that they would become hypertensive, which is why the dose got reduced to 30. I
Yeah,
have that
same
correct?
thing. Same thing happened in the NICU. Before we had nitric oxide, we used a drug called tolazoline. And it worked great as a pulmonary dilator, but then it became hypotensive. We just didn't manage
Yeah,
that.
yeah. So that fits, that was systemic, right? So that fits over.
So it was both, it was a, yeah, it was general.
Okay, so this is a paper we published in Lancet a couple of years ago. If you look at the fine print here, there are probably some names of people who you know, present company included. So we wrote this review in Lancet about selective pulmonary vasodilators and other things in the review. But the journal drew this really nice figure that I like to use in my lectures, showing how inhaled nitric oxide or aerosolized prostacyclin will selectively go to the ventilated alveolus. That will increase the blood flow to the ventilated alveolus. That will result in an increase in PO2 as well as a decrease in pulmonary vascular resistance, and the drug does not make it into the unventilated alveolus. So, by the way, before I go to this slide, so there is no debate. I don't think anybody debates this physiology. The real debate is whether it makes any difference. So does it make any difference at all as far as patient outcomes? And in the case of nitric oxide, also the effect on the cost of the drug. And to date, there is precious little evidence, none that I'm aware of, that selective pulmonary vasodilation in patients with ARDS results in better outcomes. And it's very expensive in the form of nitric oxide, as you know. But the physiology, which is what we're talking about today, the physiology is correct. So just over the last 10 years or so, there has been an increased use, there has been an increased interest in the use of inhaled prostacyclins, like Flolan, Velitri, in patients with ARDS. And what has driven that is that it is much less costly. So the cost of inhaled prostacyclin, aerosolized prostacyclin, is a fraction of the cost of inhaled nitric oxide. And I think an important point to make is that the reason, what has really driven the use of aerosolized prostacyclins is the cost, not evidence that it's better. I don't know of any evidence that shows that the physiologic effects of aerosolized prostacyclin are better than nitric oxide. I don't know of any evidence that shows that aerosolized prostacyclins increase outcomes in patients with ARDS, but it is a lot cheaper. And I have actually argued sometimes that with aerosolized prostacyclin, we've only traded one on-proven therapy for another on-proven therapy, but at least it's a much cheaper therapy. This is a meta-analysis done a few years ago looking at inhaled prostacyclins in patients with ARDS. And here we're looking at the effect of PF ratio. So the vertical line here at 0 means no effect. So you can see that with the use of aerosolized prostacyclins, there is actually a pretty reasonable effect as far as oxygenation. So aerosolized prostacyclin is a pulmonary vasodilator, and it does improve shunt, and it does improve oxygenation. So the physiology is, I don't think, is arguable. But also there is, in the same meta-analysis, looking at pulmonary artery pressure. Again, the vertical line at 0 is no difference with the use of aerosolized prostacyclin in patients with ARDS. There is a reduction in pulmonary artery pressure. So inhaled prostacyclin is a pulmonary vasodilator, and to some extent a selective pulmonary vasodilator. However, in this same meta-analysis, they showed that in almost 20% of patients in these observational studies, there was hypotension. So if when nitric oxide gets into the pulmonary vasculature, it's very quickly bound up by hemoglobin, as we said, does not have a systemic effect. The same is not true for aerosolized prostacyclins if they are used at a higher dose. So particularly at higher doses, aerosolized prostacyclins can spill over into the pulmonary circulation and cause downstream hypertension. And again, outcome studies are lacking. I do not know of any randomized controlled trial that shows that patients with ARDS are more likely to survive if we give them aerosolized prostacyclin. Their PO2 may get a little bit better, their PA pressures may get a little bit better, and that, of course, at the bedside makes us feel better, but studies have not shown that that translates into better outcomes. So then, something that gets debated still sometimes is whether we should use inhaled nitric oxide or prostacyclin. Well, both are selective pulmonary vasodilators. Either can reduce pulmonary vascular resistance in patients with pulmonary hypertension. Either can improve shunt in patients with ARDS because of their selective vasodilation. Neither is FDA approved for inhalation in patients with ARDS. One has an approved delivery system, which is nitric oxide. The delivery system that is used for aerosolized prostacyclins is, in every hospital, is kind of a jury-rig system. There's not a approved system. Neither has been shown to improve outcome. One is expensive, nitric oxide, whereas the other is relatively inexpensive, particularly in the case of Volitri prostacyclin. Now, what about the effect of lung volume on pulmonary vascular resistance? So here we're looking at pulmonary vascular resistance as a function of lung volume. And you can see that the lowest pulmonary vascular resistance corresponds to a normal functional residual capacity. So let's imagine now our patient with ARDS who gets intubated and we put on the ventilator. They have a very low lung volume because of atelectasis and so forth. So they are here. So now if we increase the PEEP and we increase lung volume as a result of recruitment, what will happen to pulmonary vascular resistance? It will go down. So we would expect then that the patient's hemodynamics would improve. So if there's less pulmonary vascular resistance, better left heart filling, better cardiac output, better systemic blood pressure. But now if we overshoot with the PEEP, and the PEEP results in over-distension, an increase in lung volume, that will increase the pulmonary vascular resistance, and that could contribute to some of the adverse hemodynamic effects we see with the use of PEEP. So if we set our PEEP correctly, that should improve pulmonary vascular resistance. Too little or too much will result in an increase in pulmonary vascular resistance. What about the effect of positive pressure on pulmonary vascular resistance? So imagine here that we have two alveoli, and one alveolus is consolidated, is not being ventilated. And now we increase the PEEP. The PEEP is not going to affect this alveolus, which is consolidated, but the PEEP will increase the volume of the already opened alveolus. So if we add too much positive pressure, we add too much PEEP, then we can over-distend this already opened alveolus. That will increase the resistance to blood flow past this alveolus and redirect blood flow from the normal alveolus to the sick alveolus. So that's the mechanism then that explains sometimes when we increase PEEP in a patient with ARDS, their oxygen saturation goes down. The reason why the oxygen saturation goes down may be because of the effect of the positive pressure on distribution of blood flow in the lungs, redirecting more blood flow to the sicker part of the lung. So positive pressure, excessive positive pressure, can have the effect opposite of an inhaled vasodilator. So with an inhaled vasodilator, that would tend to redirect more blood flow to this part of the lung. With overdistension, that will tend to direct more blood flow away from the normal part of the lung. Okay, a few words about pulmonary vasoconstriction. So here we're looking at blood flow, or we can think of this as pulmonary vascular resistance as an effect, as a function of alveolar PO2. And you can see that as the alveolar PO2 decreases, the amount of blood flow past the lung unit decreases as well. And the effect is most dramatic once we get to an alveolar PO2 of about 60 and below. So that is what is commonly called hypoxic pulmonary vasoconstriction. So hypoxia or hypoxemia increases pulmonary vascular resistance. Normally, that is protective. So for you or me, that would be a protective effect. So if I were to get a right-sided pneumonia, my PO2 may drop from 90 to 65, but not nearly as much as you might expect that it would drop for that severity of pneumonia. And the reason for that is because of this effect. Because my right lung would be hypoxic, there would be hypoxic pulmonary vasoconstriction. That would redirect more blood flow to the left side of the left lung, which is functioning normally. So it would tend to maintain the VQ and lessen the effect of the shunt. However, it is maladaptive if there is generalized hypoxemia, such as in patients with COPD. So patients with COPD typically have pulmonary arterial hypertension, and that is worsened by hypoxemia, and in fact an indication for oxygen therapy, or a reason for administering oxygen chronically in patients with COPD, is to improve their pulmonary vascular resistance. Because if we can increase their PO2 from 55 to 70, then there will be less of this effect. So oxygen therapy decreases pulmonary vascular resistance, and that's part of the reason why patients with COPD and pulmonary arterial hypertension receive oxygen therapy. Now, there are a number of things that can cause pulmonary arterial hypertension. And by definition, pulmonary arterial hypertension is a mean pulmonary artery pressure of less than or equal to 25 millimeters of mercury. So we had shown way back on one of the first slides that normally the mean pulmonary arterial pressure is about 15. So over 25 is by definition pulmonary arterial hypertension. And that is diagnosed in the cath lab by placing a pulmonary artery catheter. So there are types of pulmonary arterial disease that can cause pulmonary hypertension, like idiopathic or familial pulmonary artery hypertension, connective tissue diseases like scleroderma, portal hypertension, so patients with liver disease who develop pulmonary arterial hypertension, HIV, Eisenmenger syndrome, drugs, particularly anorexic drugs like methamphetamines, and in babies, persistent pulmonary hypertension of the newborn. Left heart disease will increase the pulmonary artery pressure because of left heart failure, so systemic or diastolic function, valvular diseases. And then there are lung diseases that can produce pulmonary hypertension, like COPD, that we had already mentioned. ARDS causes an increase in pulmonary artery pressure. Idiopathic pulmonary fibrosis causes pulmonary hypertension, and sleep-disordered breathing causes pulmonary hypertension. I should say untreated sleep-disordered breathing, and that is likely the result of repeated hypoxic episodes due to upper airway obstruction. Thrombotic and embolic disease, such as pulmonary embolism and some other rare things, can cause pulmonary arterial hypertension. And then there are some other diseases, rare diseases that can cause pulmonary arterial hypertension. So lots of things that can cause a patient to have pulmonary hypertension. So with pulmonary arterial hypertension, there is vasoconstriction and vascular remodeling in the precapillary segments of the pulmonary vasculature. So there's not just the vasoconstriction, but there's remodeling of the vasculature. So the pulmonary vasodilators might not work as well as we expect that they might work because the vasoconstriction is only part of the problem. Idiopathic pulmonary arterial hypertension has an unexplained cause, and that's probably the majority of cases of pulmonary arterial hypertension. And as right ventricular afterload increases with the worsening of our pulmonary arterial hypertension, right ventricular hypertrophy, dilation, and failure can occur, and that is what we call, that's what we refer to as cor pulmonale, which is right heart failure caused by a primary disorder of the respiratory system. So, right heart failure due to a problem within the lungs. And the most common causes of cor pulmonale are COPD and idiopathic pulmonary fibrosis. And patients with COPD typically have pulmonary arterial hypertension, and they also have cor pulmonale or right heart failure. And by administering oxygen therapy, we can reduce the amount of cor pulmonale. So what are some of the treatments then for pulmonary arterial hypertension? So some of these will affect us as respiratory therapists. So there are primarily three groups of drugs: the prostacyclin analogs, the endothelin receptor antagonists, and the phosphodiesterase 5 inhibitors. And the ones that affect our practice primarily as respiratory therapists are the prostacyclin analogs. So the three drugs here, the three primary drugs are epoprostenol, which can be administered intravenously or by inhalation, aerosolized Velitri, which is not FDA approved, or iloprost, which is FDA approved and requires a special nebulizer, as we'll look at in a minute, and treprostinil, which can be administered subcutaneously, intravenously, or by inhalation, and we'll look at the device for that in a minute. Endothelin receptor antagonist, bosentan, which is an oral agent, is probably the most commonly used, and increasingly phosphodiesterase 5 inhibitors like sildenafil or tadalafil are used as well. So these are Viagra and forget what the brand name is for tadalafil. You see it advertised on television all the time, but not for pulmonary arterial hypertension. Okay, so let's talk then a little bit about the inhaled drugs, aerosols, that are FDA approved for the treatment of pulmonary arterial hypertension. And they are iloprost and treprostinil. So iloprost is Ventavis, is the brand name. It is administered by this device, which you may have seen, which is a mesh nebulizer, and it uses adaptive aerosol delivery. This is the iNeb device. And it's kind of clever how it works. How it works is the patient puts the mouthpiece into their mouth, and then they begin breathing through the device. The device learns the breathing pattern of the patient, and then it injects the aerosol at the front end of the breath, as you can see by the grayed areas. So by injecting the aerosol at the front end of the breath, it will be more likely that the aerosol will go deep into the lungs, to the alveolar space, rather than in the proximal airway. Patients use this 6 to 9 times a day. The other FDA-approved aerosol for pulmonary arterial hypertension is treprostinil. The brand name is Tyvaso. This is administered 4 times a day, 3 inhalations per session. This uses an ultrasonic nebulizer, And if you have ever worked with one of these devices, I think the most impressive thing about this device is all of the pieces. So if you've ever tried to help a patient to take this apart and clean it and so forth, there are lots of pieces. Manufacturer claims that it's impossible to put it back together incorrectly, but it can make you look like a fool when you're trying to figure out what goes where. So this is the original device that, and I think that goes by the name Optineb sometimes, but this is the original device that came out with treprostinil now almost 10 years ago, and I'm really surprised they haven't come out with a better device yet. Have you used it at all, Liz or Patty? It's
A while ago.
I have not used it in course, but I've seen it.
Yeah.
yeah, it is.
And the windowsill is like,
Oh, yeah.
Yeah, there are just
It's
pieces
everything.
everywhere, and you know, it's like you would need a college degree in order to be able to you'd need an engineering degree probably to put the whole thing together. So this is an ultrasonic nebulizer. This is a mesh nebulizer, but they're both FDA approved for the treatment of pulmonary arterial hypertension. Okay, just a couple more slides that I will buzz through related to pulmonary embolism, and then maybe we'll stop there. So PE is relatively common in critically ill patients and in mechanically ventilated patients. It's been reported to occur in as many as 1 in 4 critically ill patients. And interestingly, many of those cases go undetected. So it occurs in about 25% of critically ill patients, but there was only clinical suspicion in about 1/3 of those patients. So it probably happens more commonly than we appreciate. Venous thromboembolism includes both DVT and PE. Approximately 90% of the cases arise from the deep venous circulation in the lower limbs, and the effect of PE is to increase pulmonary arterial pressure and increase right ventricular afterload and cause hemodynamic effects in that way. So there are a number of risk factors for pulmonary embolism, like mechanical ventilation, immobility. That's a lot of the patients that we see. Femoral venous catheters, sedation and paralysis, vasopressors, platelet infusion, sepsis. So if you look at these risk factors, that's a lot of the patients that we take care of. Non-ICU risk factors include older age, history of thromboembolism, obesity, lots of medical comorbidities, hereditary easy for me to say, hypercoagulable states, something like that. And then surgical patients are at greater risk. So as far as diagnosis, clinical features tend to be non-specific. So they include things like pleuritic chest pain, tachypnea, dyspnea, hypoxemia, hemoptysis. That occurs related to other things as well, so it's non-specific. VQ scanning is not practical at all, and for critically ill patients. You still get a patient every so often they want to take for a VQ scan who's on a ventilator. That is really, yeah, that's really a challenge.
Liz, do you? I mean, I think so. Other than
PE protocol.
It's really, yeah, it's really a challenge technically to do that. And the requirements that the nuclear medicine people have aren't very compatible in some ways with being able to ventilate the patient. So, as Liz just said, so spiral CT angiography is the most commonly used as a diagnostic tool for PE. That's what, 80% of your transports probably are for PE protocol. Pulmonary angiography, where the patient goes to cath lab or goes to radiology and has dye injected into the pulmonary artery, is rarely indicated because CT pulmonary angiography is really quite good. D-dimers are probably always done. They are non-specific, but a negative D-dimer can rule out venous thromboembolism. So treatment is anticoagulation for severe PE, thrombolytic therapy, for really severe PE, maybe surgical embolectomy. I don't know how many IVC filters are still placed anymore. Do you see them at all? It's very controversial. So years ago, they used to put in a lot of them, but now it is really controversial, and I think they have gotten away from putting them in.
We had a couple cardiac surgery.
Have you?
Yeah.
But I think they're being put in a lot less frequently than they
They might
usually.
take them out more than they.
So that is really where some of the controversy is, that they would put them in and then they would just stay in, and then there would be complications 6 months, 8 months, a year down the road. So I think you're right, when they do put them in, they probably, the ones that I think are used now are much easier to take back out. So it's sort of the umbrella inflates, and then you can collapse it and take it back out. So I think you're actually right about that. So when they're used, it's probably short-term use. So distribution of pulmonary blood flow, what this illustrates is if we look at blood flow as a function of the distance up the lungs, if we were to inject radioactive material, for example, and as you can see here, most of the blood flow is to the bottom of the lung, or the dependent part of the lung, which can be manipulated by posture. So in an upright position, most of the blood flows here. If you lay down flat, supine, most of the blood flow is to the posterior aspects of the lung. If you stand on your head, most of the blood flow is going to be to the apex. So it's a gravity effect. So that can be manipulated with position changes, like with prone positioning, for example. And then I think this is my final concept, so which has to do with the west zones in the lungs. And there is west zone 1 in the more non-dependent part of the lungs, west zone 3 in the more dependent part of the lungs, and west zone 2, which is actually most of the lung probably normally, and is more central in the lung. I take that back. Zone 3 is actually most of the normal lung. So this is sort of divided up as third, third, third. This may be like 2/3, and this is usually almost 0, and then this is the remainder. So in zone 1, the pressure in the alveolus is greater than the pressure in the pulmonary capillary. So in zone 1, near the apex in the upright individual, there is ventilation without blood flow. And that is, by definition, dead space. So for you and me and normal people, that is very low. And it tends to be at the top, towards the apex in the upright position. Zone 1 can be increased with things like positive pressure ventilation. So if we increase the alveolar pressure, then we can collapse more pulmonary capillaries and increase the amount of dead space and increase the amount of zone 1. In zone 3, at the bottom, the pulmonary arterial pressure is greater than the pulmonary venous pressure, and both are greater than the pressure in the alveolus. So in zone 3, which is for you and me, most of our lung, in zone 3, the alveolar pressure has no effect on pulmonary blood flow. In zone 2, the pulmonary arterial pressure is greater than the alveolar pressure. Both are greater than the pulmonary venous pressure. And in zone 3, the resistance to blood flow is determined by the difference between the alveolar pressure and the pulmonary capillary pressure. So again, and I don't think I said this correctly initially, you and me have very little zone 1, mostly zone 3, a little bit of zone 2, but with positive pressure ventilation, particularly positive pressure ventilation with PEEP, we can increase the amount of zone 1 and the amount of zone 2. And we don't want to produce a lot of zone 1 because that makes more dead space. Then it's more difficult to ventilate. And zone 3 is increased with volume loading. Okay, this must be the last slide. This is summary. I was thinking finally. But I started 10 minutes late. I had this intended to be a 1-hour lecture, so I guess it worked out. So pulmonary circulation is normally low pressure and low resistance. Pulmonary vascular resistance is calculated this should be from the mean pulmonary artery pressure, left atrial pressure, and cardiac output. It always amazes me. I look at my slides about 100 times before I give the talk, and then I'm standing up here and I see a typo. A number of pathophysiology factors and medications can increase or decrease pulmonary vascular resistance, and we talked about some of those. And distribution of blood flow in the lungs is determined by pulmonary arterial pressure, pulmonary venous pressure, and alveolar pressure. So in our series now, we've talked about ventilation, we talked about diffusion, we talked about blood flow, and the next time I come, we're going to talk about VQ, matching, and causes of hypoxemia.
I like your hat.
Okay.
Thank you.
Thank you very much.
Thank you.